Okay, I think we're about good to go, and so we'll get started here tonight. I'd just like to introduce myself to you guys. I'm Dr. Creer. I'm working with Dr. Jared Nielsen now at the Nielsen Clinic. And tonight we're going to be talking a little bit more about concussions. And I'll give you a little bit of background of what I do. I've been graduated for about 2 months now as a chiropractor. I love it. I love what I do. I love adjusting people, and I love treating people. It gives me a big rush after every single time I treat them. I have a master's in sports and exercise science, along with my doctorate of chiropractic, and so I like to specialize a little bit towards the sports medicine side and really treat patients that fall towards that arena. So tonight we're going to be talking about concussions, and we got a game plan. We're going to explain what concussions are, how we screen, what are some outcomes of concussions, what are some treatments even. A lot of people don't have a lot of ideas for treatments of what they can do for a concussion. And so tonight we're going to approach that a little bit and see what we can find out. Still, what is a concussion? We need to understand that it's one of the most complex injuries to diagnose, and it's still extremely poorly understood. So most of what we do right now is best of what we know of all the professional practitioners and doctors. We follow their consensus or their opinion, what we really think we should do. Right now we're trying to favor being on the safe side. And so a lot of times when we're suspicious of having a head injury or concussion, we're pulling them out and we're keeping them out until we can actually get a realistic look and see if they really do have a concussion. Now we need to note there's significant variability of presentation when somebody has a concussion. Somebody may appear perfectly fine. Somebody might be really dizzy. We can have a headache. Somebody might get really emotional. We might start crying if they're in a football game. We're saying, I don't know what happened, coach. You just got me. You're like, what's wrong with you? Yeah, and it's just not an appropriate response for that condition that they're in. But there's significant variability. It can change from person to person, can change from concussion to concussion. It's never going to be the same. Well, it can be, but it doesn't have to be, and a lot of times that is not the case. And we need to know there's no perfect diagnostic test for making an immediate diagnosis, especially in a sports setting. When we take them off to the side, we have our protocols that we run through to see if it might be suspected, see if we might want to have a further look at it. But we have no perfect test in which we can actually make a diagnosis here in that setting. Okay, so as we move on to a concussion, I've got a few different descriptions of what a concussion is right up here. Now, the American Medical Society for Sports Medicine, they make it pretty simple, and they say, simply, a concussion is a traumatically induced transient disturbance of brain function. A lot of times we hear it as a brain bruise, which that may be. But when we have the disturbance of a brain function, a lot of things are happening pathophysiologically in the brain that we can't necessarily see. But their brain's a little bit rattled, and it's not working as it should. And so essentially that's a concussion there. And then the New Zurich statement, which happened, we have the SCATs back here, and they have a conference for that about every 4 years to decide, okay, what's going to be our new protocol for how we're going to diagnose concussion, how are we going to do that on the sidelines. And this is about half of it right here, but I think it's the most important part, where it simply says a concussion is a brain injury and is defined as a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. And so it's traumatic injury that alters the function of the brain. It doesn't mean that it has to be a direct hit to the head to make that happen. You can be tackled and just kind of move your head, whiplash one way or the other. It can happen in a car accident. You don't have to have a clean, fresh shot to the brain to make this happen. And concussion is also classified as a mild traumatic brain injury just because it's self-resolving. A lot of people try to say that it's kind of in flux because a mild brain injury doesn't necessarily exist. And I'll talk to you about that. But they call it that because it can be self-resolving, meaning it'll heal itself over time. Okay, so the major signs and symptoms. We just have a long list for you right here. You can take a look at some of those. But the main two symptoms, number one, the one that you will see most of the time with concussion is a headache. That's what's going to happen. Number two, the second most common, is dizziness. And there's also a study that's if football players experience dizziness, that might actually prolong their recovery a little bit longer, if that's their main symptom. But normally headache is the one that you're going to see. But those also may be absent. So some physical signs that you may see, some things that you might see them, loss of consciousness. A lot of people say, yeah, I got knocked out, definitely had a concussion. Well, it can happen like that, but that's not the majority of concussions. As a matter of fact, it's a very small portion of concussions, less than 10%. Amnesia or memory problems is what we have going through there. They might not remember the event. They might not remember the things that happened surrounding the event. They can lose that. Balance is something that we really look for, and really it's a pretty good test if we're able to get the right things down. If we do balance and they can't have it, very likely a concussion in that way. And there's just some other ones that you can see through there as well. But you also want to pay attention to their behavior. You can see irritability. They're just like, ugh, don't touch me. Why are you talking to me like that? I'm sorry, man, just wanted to get you some water. That's it. Like, don't do it. They can be irritable. They can be overly emotional, such as the crying football player that we talked about before. I'm just like, I don't know what happened. That can happen. And personality changes. Now, if you know the person, you might be able to recognize this a little bit more. And then cognitive. When we talk about cognitive, we're talking about how the brain works, how it functions, and how they're able to think through things. That's when we see the memory problems, slow reaction time, especially for coaches if they're out there on the field or anything like that. They may notice he's moving just a little bit slower than what he normally would. As for a coach, you'd want to know about that. It's like, you're not moving right. I'd want to make sure about that. Confusion and difficulty concentrating. When you have a concussion, sometimes that's really difficult to do. Really, really difficult to do. Concentration can be quite a bugger. It was for me and one of mine, so. Okay, so sideline intervention. Once we see that the player went down, or the concussion might be possible, we try to get out there, boom. First thing we need to do is rule out a serious skull and spinal injury, and you make sure it's safe to move them off the field. We need to do a neurologic exam, such as feeling their foot, see if they can feel our pressure that we're playing on their foot, see if they can do any resistance to it, give you any feedback, and let you know if they can feel it. We want to do a cranial nerve exam. We have a series of nerves in our brain that there's 12 of them, and we can test those really quickly to see if any of them have been harmed or hampered, and that's something that we can do on the field to see if there's been anything that's been compromised through the play. We want to examine their neck, not just because we're chiropractors, but we definitely want to know what's happening down there. A lot of times that pain can refer down, and it'll let us know, too, if they have any instance of instability where that neck moved a little bit too much, where they might have torn some muscles and things like that due to the blunt head trauma that they had. So a lot of times neck issues can be an indication of a possible concussion that we have. Then we bring them to the side if they're safe to bring, and we want them to sit for 10 to 15 minutes. Reason for that, this is before we test them. Reason for that is we want to avoid the influence of exertion or fatigue when we run the SCAT3. And so you just want them to relax and you want to have them monitored. They need to be monitored. If we have somebody that has a concussion, suspected concussion, really they shouldn't be left alone for the next 24 or 48 hours, because that's when maybe concussion symptoms can probably come forth, is 24 to 48 hours later. That's why it's so difficult to really make the judgment when you're on the field. And then we're going to perform the SCAT3, which we're going to get to in just a second. I'm going to let you see what that would look like. And then we want to check vitals. Monitor those every 5-10 minutes, which we don't necessarily want to check temperature when we're on the side. It's a little bit on the outside. We don't worry about that one as much. Blood pressure. I know we have a few people out here that understand maybe pulse pressures a little bit and what those are, but with blood pressures, there's two different readings. We have the first reading, which is called the systolic pressure. And the second reading is the diastolic. Now, average for those is about 120 over 80. And so that's a difference of about 40. That's what the pulse pressure is 40. The difference between 120 and 80. If the pulse pressure gets up to above 60, and that's indicated of a possible cerebral hemorrhage and fracture up there, and you want to get into the hospital immediately. You want to check their breathing and their pulse as well, because if you notice any changes, deterioration with those, we're getting them out of there. See, something might be happening with those. And so SCAT3, we have a few of those back in the back. I also have one right here. If you have these, you can follow along. The SCAT3 actually works really, really well and lets you know really what a concussion is. Now we have a child SCAT and we've got the SCAT3. We'll just look at the SCAT3, which is for patients that are 13 and above. And then the child SCAT is for 5 through 12. And so it's got a little bit of information on here to let you know what the SCAT3 is. It's a standardized tool for evaluating injured athletes for concussion. just to kind of get an idea if this might be the issue. Now, patients may have a perfect SCAT-3. They might not have any issues with it at all, but it's not saying that they don't have a concussion. And so that's important to rule out, but it lets us know, it gives us a good idea as if they'd be indicated to doing that. So it's got on here a few different things. It says, what is a concussion? It lets you know. There are things that we've been over here a little bit. And then the sideline assessment. We have a few things on here, such as, is there any loss of consciousness? If so, how long? And questions of such. On here we also have the Glasgow Coma scale, which we had on one of the previous slides. But it's essentially a score out of 15. If they score below 15 at all, you are perfectly validated to send them to the hospital, according to this. But you can do that. I don't know if I really necessarily would or not, though, depending on what you're seeing and what is happening in that immediate moment. But essentially what you're testing with that is you're testing their eye response. If they respond to pain, if they move their eyes, if they open their eyes at all, if they respond to you calling their name, you want to know about that. Verbal response, if they can respond to you at all, if they can say anything. And then we have a motor response, meaning are they moving? Do they go to the pain? Do they have full movement? Do they not have any movement at all? We need to know that. And so as we get them on the side, we want to know their background. Now we also do baseline screens here with the SCATs as well. Typically with the high school athletes, we'll do the baseline screening with them to have an idea of where they're at the beginning, before they even start. And then we'll compare their SCAT from their baseline to after and see if we have any differences. Now a lot of these right here, we talked about signs and symptoms. They have a whole list right here. How do you feel? And rate how you feel. And that's up to the athlete right there to be able to finish that, even when they're sitting on the sideline there after that 10, 15 minutes. They will circle how they feel. It's up to them to do this portion of the SCAT. Then we have questions to see if it worsens with physical or mental activity. I think it's a good indicator for us there as well. Then we get into a little bit of a cognitive assessment. With the cognitive assessments, we essentially want to ask, what month is it? What is the date today? What is the day of the week? What year is it? And what time is it right now? Just to see how their present orientation is and how they're feeling. Then we have a few different, now this one for me is difficult even at times too. We'll give them a list of words, a list of 5 words, and have them respond back to us 3 different times. And we'll just write it down what their scores are. If they get all 5, they get all 5. And this one right here is the difficult one. We have them do the digits backwards. Yeah. And so if I were to ask you right now, can you repeat back to me these numbers backwards? 493.
93.
Say it backwards.
9.
Exactly. Okay. Yep, that one starts to get me a little bit too, especially when you get going on, because you'll get down to about the six numbers. Like we can just ask Kemi right here, 793261. Yep. Yes. Now, I said those a little bit fast. We want to say them typically at about this rate of 1 a second, so you can kind of get that and understand it. And you can think about it and move it back. Now, an easier question that we do to assess this as well is just ask them, okay, can you say the months backwards, starting with December, November, and let them take over and see how they do. It's kind of interesting to see how a lot of people kind of miss that one a little bit too. Then we have a neck examination. So we'll examine the neck, and then we want to test the balance. There's a few different things that we want to do for balance. We want them to stand ahead, feet about shoulder width apart, and their hands on their hips right here, and close their eyes, and have them stand there for about 20 seconds. Now, if they bend their hips more than 30 degrees, that's an error. They start to lift a foot in that's an error. They can have up to a maximum of 10 errors. If it gets that far or they just can't do it at all, or they reach out to grab something, take their hands off their hips, it's an error. And so we'll count those. And there's a few different ones that we do for these as well. We'll have them do what their non-dominant foot is. Ask them, what leg do you kick with? What foot do you kick with? They kick with a separate foot or their non-dominant foot. We'll have them balance on that one. Slightly flex the knee, or the opposite knee, just like this, the hip and the knee. Have them stand right there for 20 seconds. Once again, counting those same errors. And then tandem, we put the non-dominant foot in the front and have them do it again. And I do that for you guys, but it'd be a little bit too funny for you guys tonight. You'd probably be laughing because I really struggle to do that. I might get about 3 or 4 seconds and boom, I'm done. And so that's why it's important why we do the baseline testing so we know really how they're doing. Okay. And then we have a coordination, which is testing. These are all testing different parts of the brain, getting a little bit of assessment. As we do those balance tests as well, typically if we know that there's a balance issue, it's going to be indicated for a concussion. But when you're in a football setting, when you're in a basketball setting or anything like that, they could have a lower extremity injury that's causing them to be like that. Their shoes, their cleats, it may cause them to be a little bit different because typically you'd like them to do this barefoot to really get a true idea of what they're doing it. And sometimes that's really tough to do in a sports setting, especially if they've got tape all around their shoes and everything, and just even know what kind of problems they have going on in their lower extremity that may have happened during the game. Okay, and then we have the delayed recall. That list of 5 words that we had previously, we go back and we say, of those 5 words, which ones can you remember? Like, oh, no. You don't let them know beforehand that you're going to ask them to do that, but you say, can you just remember any of those words right now? And see if they have a little bit of delayed recall. And so with that as well, the next page right here essentially tells you how to do everything right there. It takes you through the whole scat. It says, this is what you should say. This is what you should look for. And so it's really helpful and tells you everything right there in the scat. And then there's athlete information. Things you want to look for. Things that make it worse, and when you should really make an emergent recovery. And so at the top of the 4th page right here has athlete information. And so we'll have this in the next slide right here a little bit. A headache that gets worse if you're drowsy or can't be awakened. No, you're fine right here. You can see that little list right there. And then we have our return to play there as well, which we'll cover just a little bit here. But these are also some other warning signs. Age can be an issue. If you're a child or an adolescent below 18 years old, that's going to be, typically it takes them longer to recover from concussions, just due to the age and development and things like that. Recurrent concussions, or a threshold, because concussions with less impact and slower recovery. They ask that in the history here to let us know with that. Mental health disorders, ADHD, depression, and things like that can have a negative prognosis there with those. And even migraines. If you have migraines, it's been shown with those a little bit that they can have a negative prognosis. And if you're on any medication, that's why it's important that you really declassify that here when you or classify that and let them know, the person who's assessing you, of what's happening with that. Okay, so here's just some more of those warning signs for prognosis that we have. Now down here at the bottom, we have maybe loss of consciousness and amnesia, or memory loss. They think that may be an issue if it's longer than a minute, if you lose consciousness for more than a minute, but it may not be that indicative of really how serious it is. But they have that on there as an issue as well. All right, and these are emergent referrals, especially if they're having decreased neurologic function. They're losing it in their feet and that a little bit more. It's coming up. They're losing a lot of their motion. Yep, you want to get them in the emergency room. Decreased consciousness. If they're just feeling more and more out of it and are dropping out of it, emergency. Just any of these right here. That's why we need to talk about vitals with respiration and pulse. We need to look at their pupils. Sometimes we had one patient or one athlete who went down, and immediately my clinician ran out there just with the pen light. I mean, you saw it was going to be bad. He had blood all down his face and everything. You heard the thud against the ground. You're like, uh-oh. He ran out there just immediately, shined a light in his eyes, like, get him out of here. It's like, we knew it was bad. And so we were looking with some skull fractures, some facial fractures or anything like that along with that. And so that was also a reason that we got him out there. But he had no reactive pupils at all. They were completely open. And so if that's the case, you've definitely got some brain issues going on with that. You need to get that attended with pretty quickly. Signs or symptoms of bleeding of the spine or with the spine or skull fracture. A lot of times you can't see that, but sometimes you can see draining through the ears. Whether it be of blood, whether it be of cerebral spinal fluid. It's like, uh-oh, little drainage there. That's indicative as well of something happening at that point. And when we talk about the pulse pressure again, it gets above 60. You got to get them out there, because they may have some sort of hemorrhage going on in the head. And seizures as well. They have the seizures, then you need to get them out there. Okay. And then, did you want anything to add to that right there? Okay. So to return to activity right here. Now I'll let you just take a good glance at this, because essentially this is what's going to kind of take over here. Is we're talking about getting back to activity, getting back to sports, or just anything regular through your regular day. First stage, we have no activity. You need complete physical and cognitive rest. A lot of times the sound, the light, working on your phone and things like that, working on a computer can really hinder your progression as you work with this. And so you need complete physical and cognitive rest. Don't worry about it. Stay away from it. Because the objective of this one right here is going to be recovery. There's a lot of physiologic things that are happening at that point. And a lot of times, has anybody ever heard when somebody has a concussion, you want to keep them awake? Has anybody ever heard that before? Okay. They're challenging that here now as of late. I would necessarily say don't keep them awake. I would let them sleep, but have somebody there. Somebody needs to monitor them. Check their blood pressure, check their pulse. Them sleeping is essentially their brain really trying to, the rest of their body shutting down so that everything can get to the brain so it can heal a little bit better. But you need to monitor them. If you notice any decline with a lot of the other things we've talked about with their vitals, then you need to take them somewhere. But you can let them sleep. That should be okay. But they're going to be recovering in that time. Then you want light aerobic exercise, such as a walk, swim. The objective that you want to do for this one is just increase the heart rate. That's the main thing we're trying to do. Increase that heart rate a little bit. You don't want to do it too much, but give them some activity. Get that brain to work, get that heart to pump a little bit more, and see if that triggers any symptoms. And then a sport-specific exercise. You can go running and football and soccer, go skating and hockey. No contact, no real drills or anything like that, but you want to add movement to it. We're adding to the brain right here, so we're getting more heart pumping, more blood pumping into the brain, and we're adding a little bit of motion, so it's a little bit more complex for the brain to interpret it, to see how you're going, see if motion kind of re-triggers those symptoms. And if that's okay, we can go to non-contact training drills. So you can get out doing drills as you normally would, but not making the contact. And the reason for this right here, exercise coordination and cognitive load. We're adding more onto the brain right here, and we're making your body get more back into it, get into it again, and we need to have coordination. Have things working synergistically together for the best thing that we have. And then a full contact practice. If you're medically cleared, you can participate in the normal training. And this right here is essentially restore confidence. And the coaches need to assess really how you're performing to see if you're good enough to go back in. And if symptoms do not come up there, you'll be good to go. Now, this is the stage. These are all the stages that we have. And if you're through those, you can return to play. But there's a few caveats that we need to know as we go through these stages. Okay, you may not return to play the same day as a concussion, the same day it's suspected and diagnosed. Now, this is kind of the trick right here. Patient must be symptom-free for 24 hours before advancing to the next stage. So, therefore, it typically takes you about a week before you can come back, at fastest if you're diagnosed with a concussion. But to be symptom-free as well, it means that the athlete is medication-free, including amphetamines, including Tylenol, including ibuprofen, or pain medication. They need to be completely off of it. If they're on it at all, they stay in that stage until they've been symptom-free for 24 hours. So until then, that's where they are, and they're stuck. If they're using medication, they're not going to advance at all. And so, any questions or anything about that?
They're that strict with the Tylenol, huh?
They're that strict with the Tylenol, yeah. They need to know really what's happening, and they can't tell exactly what's happening if somebody's taking anything, and really see how they're feeling. So they need to be medication-free. So that's why we'll encourage patients at times, don't take it, you need to rest. There's a few other things we have that we'd like you to take, though, that'll help kind of build the brain back up and help it with its recovery. But for pain and that, not necessarily through there. Okay, and so I just have a few questions here to end right here, at least my section of it. So you can just think about these right here. I mean, I've got all the answers right there. You can see them right there. But as we can tell, the male sport with the most concussions, we're looking at football. And then there's some subsequent ones right after that there as well. The female sport with the most concussions is soccer, which kind of comes as a surprise to a lot of people. But basketball and volleyball are there. Quite a bit lower, but they're in there. But soccer and basketball are typically the ones that we look at when we're looking at concussions there with females. The next one, who is more susceptible to a concussion? That one's a female. Anybody have any idea why that might be the case?
We don't have the neck muscles that the men have.
Yeah, so it's not quite the stability. You don't have that neck stability. That's the theory that they come up with right now, is that you may not have the stability in the neck that a lot of the men have to really kind of stabilize the head when they go through the sharp blows and things like that. And so a lot of times there's a little bit more whiplash. Even a body blow can cause a concussion through that. And so women are a little bit more, the theory is that that's the reason why. They're a little bit more susceptible. They don't have quite the stability or the neck strength. In general is what most men do. Okay, I just answered what the next one is right there. A concussion only occurs with a direct blow to the head, and we already talked about that a little bit. That's false. That does not quite happen. It can be a blow anywhere. You can be hitting the leg. Anything that causes a whiplash effect there with the head may cause a concussion. And then as many as 50% of concussions are unreported. That's true. A lot of times we wonder, well, how do they even do a study like that? How can they know that 50% of the concussions are unreported? They've run a few in high school athletes, those that have been diagnosed with a concussion and those that weren't diagnosed with concussion but maybe potentially, and they gave them a questionnaire. And their symptoms that they were still having were in line with having a concussion. They were never diagnosed, but they were still having symptoms. And they've done a few studies like that, and that's about what it comes to, about 50%. So 50% of them are missed. Problem with that, if we miss a concussion, is that if they receive another concussion when their brain is trying to heal that fast, it may cause permanent damage, really traumatic damage at that point that may be irreversible. That pathophysiological cascade that's occurring in there, it's more than the brain can handle if it takes another one. And so sometimes they'll call that second impact syndrome. That's really tossed up in the air as well, but you need to know that it's out there. Sometimes it can be an instant fatality. Sometimes it's going to cause permanent damage where they may not be able to walk, they may not be able to talk, they may not be able to understand. Your brain controls all of that. Your brain controls pretty much everything in your body. When you sleep at night, do you think to breathe? You don't. When you sleep at night, you think about your heart breathing or beating? You don't. Your brain takes care of all of that. Your brain triggers everything to digestion. You don't have to think about that. But it controls everything in your body. And if you don't take care of it, bad things are going to happen to it. So on to the next one here. We have just a few more statistics and questions right here. In that video that we first watched, can concussions be diagnosed with a CT scan or MRI? No, they can't. They can't. I've heard recently that they've had some advanced MRI machines that may be a lot more sensitive and are in super high definition that might be able to discover a little bit of concussion. It's like, oh, we got a little something there, something might be there. But nothing's definitive there. And if somebody's having a traumatic brain injury at that point, I don't want to hold them trapped in something there for an hour to be able to have that MRI done. They're not going to want that. And so CT scans are actually really good to see brain bleeding or brain fractures. If we're afraid of that, we're sending them to the hospital, we're getting a CT scan because it's fast. It's fast and you can see it really, really well. But for concussions right now, not so much. They're not very good for diagnosis at all. And so the only way you can really diagnose a concussion is through a trained medical professional who has experience with concussions, who understands concussions well, and does a lot of different testing with them to really see where they're at. That's the only way you can really just diagnose it. Then 7, previous concussion can increase the risk for future concussion. That is true. Don't exactly understand why. But it seems like the more concussions you have, the longer it takes to recover, and the more symptoms you have too. And then number 8 right there, I know they mentioned in that video right there that typically 80 to 90% are back in 4 to 6 weeks. But a lot of other research will tell you that it's typically within 7 to 10 days that most concussions will resolve, that you'll be back, that you should be back. But a lot of times it's difficult to tell if a concussion is really serious or if it's not. Sidney Crosby was out for the whole year. He was a hockey player there for the Pittsburgh Penguins, and they originally told him, okay, you should be back in about a week, you should be fine. But he was out for the whole year because there were some things that he just couldn't do. You can't see exactly how serious a concussion is. Or there's Justin Morneau, who was a baseball player for the Minnesota Twins. He was an all-star. It was in May, and pitcher threw it, and it wasn't that hard. It was probably about an 86-mile-an-hour fastball, which not that hard, whatever. It's pretty hard. But Major League standards, it's not a very fast fastball. It just glanced. It didn't hit him square. It just kind of glanced off of his helmet. And he went down to first base. He was fine out on base, didn't say anything. But when the inning ended, he came back into the dugout and said, I'm just feeling a little dizzy. I go, okay, we'll hold you out here for a little while. But he wasn't able to get back until next April. He wasn't able to make it back. We're like, oh man, why not? Why can't we? How can we not tell how serious a concussion really is? We just have to take them through that protocol. And they need to be honest with what they're feeling. If they're not honest with you, then we might have some more severe things that are happening with it. And so, really how bad it looks at first is an indication of how serious the concussion may be. I can give you a few things that happen with, there's been some studies that have been done with people who were diagnosed with a concussion 30 years ago and those that hadn't been. And they took some neuroimaging of that and compared their brains. One of the biggest differences was that they had their brain seems that it had aged about 10 to 15 years more advanced than those who did not suffer a concussion. Those who had 3 or more concussions were 5-fold more likely to have mild cognitive brain issues. Could be memory, can be just your thought process, could be slurred speech. And a lot of, because we hear all the time about NFL players who have decreased lifespans, it's typically in the mid to upper 50s is where it is right now, about 15 years lower than everybody else. A lot of times they're thinking it's due to that. Due to concussions, they just age that much faster. That's what happens with it. And they lose a lot of their gray matter, that portion of the brain. Those neurons just die. And the other thing is that it really gets them into, it greatly elevates their likeliness that they will have some depression and severe depression when they get into later in life. If they have more than 3 concussions, that can happen through there as well. And so they're aging, they have depression, and they lose a lot of their cognitive function when they get older, when they have those concussion issues. Do we have anything else?
I have one question.
Yeah.
Do you know if the high schools are all using the SCAT-3 now, do you know if it's a protocol for them to use it, or?
I'm not sure what every high school's protocol is. This is what we did when we were up in Oregon. For each of the high schools that we were with, this is the standard way that we did it there, just as the school. We did the baseline studying with the SCAT, see where they were, and then if they ever had an issue in the game, we would do that as well. But I'm not sure about what it's like everywhere. They all have their, yeah, and yeah. So the SCAT, it has been, it really has been, and so the SCAT was made at the 4th Zurich Conference, which they have every 4 years. It's where the world's foremost experts in concussion get together, and they decide how they're going to modify it with the research that has come out, and how they're going to change it to help improve, help better recognize concussions, because it's really a difficult thing to really track down. But that's where it comes from, and they make that as the standard, just for in a sports setting, how they do it. Now I know we do a few things different in a functional setting when we talk about functional neurology and things like that, but they're all testing different parts of the brain, and there's things you can do with it as well to actually build the brain back up. And think that's one of the interesting things that we have with that as well. And so, would you like to talk a little bit about that? Excellent.